The content of this podcast is for informational and entertainment purposes only. It is not intended to be a substitute for professional medical advice, diagnosis, or treatment. Always seek the guidance of your healthcare provider with any questions you may have regarding your mental or physical health. The views expressed are those of the host and guests and do not replace personalized care from a licensed professional.
Welcome to Mindful Moments with Pedro Morante, a space where a nurse practitioner and educator shares real talk on mental wellness, mindfulness, and navigating life in and out of healthcare. Let's take a moment to breathe, reflect, and grow together.
It's very important, guys, to start slow, go steady. No, it's not a fast race. We're all in this together.
There's a lot of anxiety, depression, and PTSD going on. So just need to make sure that our message as a provider is heard by our minority patients. Making sure that we are here for you.
Good day to all the listeners and followers of Mindful Moments with Pedro Morante. I would like to share an exciting news that we hit 50,000 followers for our podcast. So thank you so much for all my students across the nation for following, sharing, liking, subscribing to our podcast. I'm joined today by a highly esteemed faculty. He is a keynote speaker. He is a leader in higher education, administration, and clinical practice, a Neuroscience Education Institute Master Psychopharmacologist, and a fellow of the American Association of Nurse Practitioners, America's top psychiatric NP in 2021 and 2024 by the Point of Care Network. This is Dr. Josh Hamilton. Hi, Dr. Josh Hamilton. Welcome to Mindful Moments with Pedro Morante, Nurturing Minds the Nurse Way.
Hey, it's great to be here. Thanks for the invite. It's great to catch up with you.
Thank you. I met you several years ago, and we were planning to do some collaboration. And now I'm so ecstatic and happy that it come into fruition. So thank you so much for your generous time on the Friday night. And you're from Las Vegas, Nevada. So how's the weather there?
Hey, I've escaped the heat. I'm actually closer to the East Coast this week, but I see that we're feeling summer as we always do in the desert Southwest. So as it creeps into the hundred and teens, I'm glad not to be there this week because I remember what that feels like. They say it's a dry heat, but anything over 100 is hot, no matter how you look at it.
Thank you, and I hope you're enjoying your trouble. And thank you for joining us. Let's start by sharing to our audience a little more about your journey and the work that you do, which I'm so amazed across clinical care, education, and policy, and what drew you to focus on psychiatric nursing and mental health.
Yeah, I'm probably like every other nurse practitioner, yourself included, that you've ever met. We just like to do a lot of different stuff. We like to have multiple irons in the fire. And I think I've always been that way. I was thinking as we were getting ready to start, I think this is my 29th year in nursing. I've been a nurse practitioner for 23 of those years. So time flies when we're having so much fun. But I started off knowing that I really liked neurobiology. I've always liked neuroscience and psychology, and I love sort of understanding the human animal. So I knew that was probably where my destiny would be. Like many of us, I started pre-med and pretty quickly discovered that I was not going to be a physician. I sort of backed off to kind of rechart my path, and I thought, what could I do while I'm trying to decide what to do with my life? And I thought I should become a nurse. It would make me a better physician. It would make me a better psychologist, whatever I thought I might do. Started and never looked back. So it was sort of interesting to understand that nursing was my calling. I love that worldview. I love that particular lens that we see the world through. And I've always sort of been shocked that I became a psych nurse. I really was young enough that I thought I would be a critical care nurse or I would enjoy being a flight nurse, and sort of that adrenaline junkie. So even as I was working my way through nursing school, I began as a ward clerk in a 75-bed locked inpatient psychiatric unit. So I don't know why it surprised me that that felt like a comfortable place to be as an RN. And then as I was becoming a nurse practitioner, I became an FNP first and tried primary care, but I was always gravitating back to mental health, running the clinic late because I would address mental health topics even in a primary care encounter. So as I was starting my doctoral work back in the early 2000s, I was doing so much mental health, even in primary care. I thought I better legitimize that scope. So at the same time I was working on my doctoral work, I became a PMHNP. And I've been doing that exclusively for about the last 18 years, closer to 20, I guess. So time flies, but I like a little bit of everything. I've always been a scholar practitioner. I've always had a clinical practice. I have always enjoyed teaching. I've been in the academy since 2001. And I get involved with industry and I do policy work, quite a bit of service to the profession, publish and speak frequently. So that's what's nice about nursing, right, Pedro? It's if you don't like the lane you're driving in, put your blinker on and see what else you can do over here. So I've done a lot of lane changing, and no 2 days are boring. I moved to the bipolar capital of America to become a psych mental health NP in earnest. So that's never been boring. And my travels take me all over the place to either consult or speak or teach. My telepsychiatry practice is active in 6 states from coast to coast, so I get to be in every time zone every single day. So never bored. And for me, insomnia is a superpower. So thankfully, I don't require a lot of sleep either. So that's my story.
Wow, very inspiring, Dr. Hamilton. It seems like a lot of our followers will be asking, oh my God, I want to grow up like Dr. Josh Hamilton with all those accolades and achievements that you have. I'm just so impressed and inspired to do more. And you're right. Nursing, we have a lot of avenues and it opens a lot of doors and opportunities too. So thank you so much for sharing that to your about your story. And with your deep background in pharmacology and also in your neurobiology, I'd love to dive into how our brains are actually responding to today's constant noise, such as notifications, work stress, emotional labor, and all of it. What are we really doing to our brains when we're constantly multitasking, scrolling, and overstimulated, and how it relates to depression and anhedonia?
Yeah, it's been an interesting time. I mean, I think we've had a tendency, probably since the advent of social media, if we're honest about it, um, to sort of be interesting creatures when we look back and kind of see how we've changed since the dawn of Facebook and TikTok, especially when we think about Instagram and all these iterations. And then you layer that onto the pandemic, especially. I think we've really accelerated the rate of change and insult or challenge, I think, that we subject ourselves to. So as a student of pharmacology and neurobiology, I think one of the linchpins that sort of ties all of that together for me, or at least makes me more easily relatable and makes my encounters easier, or makes it easier for me to model what we're really dealing with, is that I've always been a student of epigenetics as well. So when you think about that theory in this context, we now understand that the environment that we are subjected to, good, bad, stressful, or not, enriched or less enriched, the way the world pushes in on us actually has an effect at the genetic level. And I think it's always been interesting to me to study what that is, and that's an epigenetic function to really think about how environmental pressures, or if you like, the nature-nurture construct, the nurture piece of our lives, whether that's constant noise and notifications from social media or the stress of the pandemic, sheltering in place, and then coming out and having that re-emergence anxiety. Um, if that was our primary social construct when we were locked down, if we were multitasking and scrolling and really doing a lot more on screens, all of that pressed in on us. And I think it changed the way the brain did its business, the way that it expresses genes, the way it translates, the way it then secretes neurotransmitters, the way those neural networks communicate efficiently or not, and the types of messages those networks send are reassuring messages. They say, cheer up, calm down, sort through the noise, decide what's important, prioritize, and deal with one stimulus at a time. I think when things became more chaotic and persisted in that chaotic state, epigenetics, or those little codes that switch genes on and off, really changed the way microscopically, neurobiologically, the way those little brain cells situate. And often what it causes those cells to do is shrink back away from each other. And in that context, they don't communicate very well. So there's not a lot of self-calming or a lot of self-cheering or a lot of self-sorting, particularly in the prefrontal cortex, to say with all of this stimulus and this persistent stimulus, how are we ever supposed to reorder the way our brains process that information and the way we calm ourselves and regulate our emotions? It's been a real challenge just because of everything that came so quickly. That curve was vertical in terms of just the number of stimuli. And then the persistence of those stimuli for years as we weathered the pandemic. And now we could talk at great length about what the current political environment and the economic environment are like, but it's just been wave after wave of challenge and noise that really has been a less enriched environment, if you look at it that way. So that is a neurobiological, it's a biological basis to what many of us, most of us, are experiencing.
Wow, those are great insights, Dr. Josh Hamilton. I really love how you explain the ping, pop, and endless scrolling in relation to our prefrontal cortex. And I know that they're responsible for focus planning and also decision making with competing demands. And I know that chronic multitasking doesn't just divide our attention, but it drives up our cortisol and also our dopamine. And over time, the default mode network and responsible for our rest and reflection gets less activation. So that's why people feel wired yet depleted at the same time. Am I correct with that matter?
It is interesting, so much of that is dopamine at play.
Yeah.
And, genetically, prefrontally,
Mhm.
there's so much that we could actually predict. We're looking at vulnerability concepts now when we're trying to think about who's more vulnerable to this situation, and then trying to build resilience and resilience interventions into the work we do in the public sphere. And a lot of this we could actually predict, especially attention issues, concentration issues, prefrontal regulatory issues, by testing one gene called COMT, or catechol-O-methyltransferase. And that the form of COMT, the recipe that you inherit from your parents for that particular enzyme that actually helps regulate the efficiency of recycling of dopamine in the prefrontal in particular. You're born with a form of that in some cases makes you more susceptible to being born anxious, and in some cases to being more prone to this dysregulation that we're talking about. So there is some genetic testing. Its prognosticative value is actually pretty high. So we can study that now. And I think the other thing that we need to think more about is there are dopamine circuits through like the nucleus accumbens and some of those reward centers of the brain. So we can actually use a reward and addiction construct here as well. And some people are more prone to dysregulation in those circuits. So when you think about the reinforcing effect of social media in particular, some people are really struggling through that dopamine circuitry, which is in slightly different geography, as you know. So we've got a couple different models we could look at there.
Wow, very informational in terms of those pathways. Thank you so much for educating me too. I really like how you explain that in the most simple way that we can. And Dr. Josh Hamilton, I know you've worked nationally through telepsychiatry, which proves about innovation in our mental health care. What are you seeing in your telepsychiatry practice right now when it comes to overstimulation in relation to anhedonia and depression? And how are you helping patients navigate that both through therapeutic conversations when needed pharmacological support too?
Yeah, I think it's been a game changer. I think the obvious strengths of telepsychiatry translate really well to mental health, telehealth in general. So it has been helpful, I think, to improve access and the efficiency and speed of access for people who wouldn't normally maybe seek care, or they would have waited a long time for more traditional brick and mortar office-based care, for example. So it's been gratifying. I've been involved in telepsychiatry since before it was popular or necessary. So I actually made that shift with a large percentage of my patients back in 2015, well before the pandemic. It was a real game changer. I think the efficiency of that access to be able to step out of your office or Walk out to your car and have a quick conversation has been really helpful for many patients. The ability for those networks to reach across state lines. For me, I've been working with some of my patients and their families long enough. A 6-year-old that I might have started with in my brick and mortar practice back in 2012, 2013. In some cases, they've gone off to college. So now I'm seeing them in another state, in another phase of their development. But I think the uniform message that came, and again, probably recognizing this more during the pandemic, because we were all locked down and all accessing healthcare that way with a telehealth model. There was a lot of frantic sort of anxiety about having gone into a bubble and locked down, and then when the all clear happened, that anxiety and overstimulation of how do I navigate this world that is so different when I go back out? I think one of the things I've always done, regardless of whether that overstimulation is acute, more of an anxiety or racing presentation, or whether it's taken its toll and you're seeing the long-term sequelae, which could be something, as you mentioned, something like depression or anhedonia, or that I used to call that coping like an ostrich. We just bury our heads in the sand and wait for it to get better, and then peek your head up and see if we can navigate that world. People are in various stages of that. So you really, as a nurse practitioner, I think we do a good job tailoring or being more personal in how we understand those patients and how we empathize and get their stories. So it's not us waiting for something to be acute or waiting for it to become more problematic or chronic, but recognizing where a patient is. The other thing that's always been interesting to me, I don't know how you feel, but I went into this work in mental health because I wanted to do more than just wield a prescription pad. I'm an excellent psychopharmacologist. I'm a great neurobiologist. I mean, I have a national certification that proves that I'm pretty good that way. But I really wanted to be a therapist. I wanted to be a good counselor. I wanted to have those longer conversations. I wanted to understand the patients and their families and their situations, the communities they were living in, the unique situations in their villages where they happen to be living. And in so many instances, we share those Venn diagrams of life with them. We live shoulder to shoulder with them. We go to the same supermarkets. We find ourselves at the same performing arts centers and the same concerts. It's just two people trying to connect. So even in the telepsychiatry realm, I think one of the important things I learned as I was trying to figure out where psychotherapy and counseling fit in my practice, and I needed it there, is that it doesn't take a 50-minute traditional psychotherapy hour or formalized or manualized psychotherapy training to have effect with a good quality conversation. There's some well-known meta-analysis work that really talked about 4 big changes or 4 big factors that come into play with brief therapeutic conversations. And one of the big ones is the relationship, those relational pieces, that Rogerian warmth and that consideration we give each other accounts for about 40% of the good stuff we see from a brief encounter. And the other it's called extratherapeutic factors. It really just has to do with taking stock of strengths and weaknesses and opportunities and obstacles to think about how we can mitigate or marshal or mobilize some of those supports outside of that session. So between those two things, 80% of a brief therapeutic encounter, the therapeutic piece of it can be explained. So our brand as nurse practitioners, brief as those interventions may be, even in the telehealth environment, that enriched, warm environment where the relationship is good and where we're really surfacing strengths and weaknesses and assets, those two things can be enough to reverse some of those epigenetic suppressive changes that I was talking about. That enriched environment of that relationship can actually be as powerful as a pill, as a medication, in reversing some of those symptoms. So good bedside manner has always been important. And I can tell you, as a telepsychiatry provider, good webside manner is just as important for those reasons.
Wow, very informational in terms of how you relate it in your practice. And I'm so honored to be the first one to listen to how your story is projecting to different providers. And I think a lot of new grads will be asking, like, how did they do it? How did they do telepsychiatry? And one thing that I'm so proud of you is that you were a pioneer of telepsychiatry, and now it's everywhere. But to looking back the history of telepsychiatry, you were the first one to do it. So proud of you, Dr. Josh Hamilton, and thank you for sharing those survival tips for the new grad nurses or PMHNPs that are trying to transition into practice.
Thanks for your kind words. I appreciate that.
And then my follow-up question is, in what ways does virtual care help patients feel more comfortable opening up about their stress, anxiety, and overstimulation? And are there any certain conditions or moments when telepsychiatry is more effective than in-person care in your practice?
It's a really interesting consideration, isn't it? I mean, I think honestly, I'm meeting patients that may have been lost to care because they either have elements of, if not diagnosable agoraphobia, for example, they just don't feel comfortable either driving on a busy freeway to get to a more traditional office-based appointment. Maybe they're having issues or they're so debilitated they can't groom adequately to feel comfortable going out in public. You know, some people are anxious about their appearance, anxious about traffic, anxious about parking, all of those big question marks looming out on the horizon when you think about leaving the house to go seek mental health care, which for some reason is still highly stigmatized in certain people's life models. So I think it is helpful to reach those kinds of patients who can open up and or will at least access a visit, even if it's difficult for the first session or two, from the comfort of their own environment. You know, right now, knowing this is my office behind me, this is my domain, I haven't had to leave it. If worse came to worse, I could stop this session and it wouldn't be me in an embarrassed moment feeling awkward and having to call a timeout in someone else's office in someone else's domain. They feel more in control of as many variables as they can control. So I think it's easier because they don't have extraneous stress going on. You know, there are anxieties that go with accessing healthcare. Even going in, I mean, think about it, take it away from mental health for a minute. Having to go in to a traditional physician's office or primary care provider's office just to have a sore throat looked at. There is stress associated with all of the logistics of getting there, checking in, meeting strangers. There's a smell to those clinics, there's a feel to those clinics. Whereas if you could just open your mouth and shine your cell phone flashlight in and have a telehealth encounter where someone says, yeah, that looks like you've got reddened tonsils, you've got some signs that you've got some sort of laryngitis, or maybe there's the need to get a throat culture. It just makes it so much easier for those folks who have those anxieties to talk about it. And I think that's true when you're feeling overstimulated or overburdened, or as during the pandemic, anxious about infection or anxious about exposure. Telehealth really makes healthcare accessible, and the mental health conversations are, I think, much more effective on that note. It's a calmer, more controlled environment in which to have those interactions and those conversations, really non-threatening. I was always afraid, and I guess there are some instances where I feel like as much as that seems like an asset, I'm just touchy-feely enough, especially with kids. I think there's a certain subset of pediatric patients in particular, especially young children, where there is an irreplaceable component to holding physical space with somebody, especially if you're trying to observe behavior or get a better handle on affect or long regulatory periods just to see if there's vacillations. And that's a place where office-based care can be superior, but those are so few and far between. So I think it's just really the state of the art. And I think in some ways it has so many more assets, so many more positive attributes. It's hard for me to think about going back.
I love how you emphasize on those key tips that new psych NPs could get from this conversation. You talk about patients are often in their own environment. Sometimes, with my experience right now, they could be in their pajamas or curled up with their pets. And they can lower the psychological barrier to honesty because they have a sense of safe space when they're talking to their providers also. And I think overstimulation and anxiety are discussed more openly in telepsychiatry because people don't have to push through the stress of commuting, waiting rooms, and time away from their responsibilities. And that's something that I learned from you today too, which connects with my practice. So thank you so much for emphasizing that. And then another question that I would like to ask you, Dr. Josh, is a lot of people are exhausted but still performing. What's the danger in ignoring that? And how do you see this play out, particularly in healthcare workers and nurse practitioners, especially the new grad psych NPs right now?
It's one of those things that didn't really become eye-opening to me. I mean, I guess most of my colleagues, we've always been over-actualized, right? So we're always bumping around like pinballs. That is our default mode. So we're used to that. What I didn't realize was going on, and it took a lot of steps for me to see, especially during and through the pandemic. And I keep going back to that. There was a trauma to that period of time, and I think I didn't see it wash through the healthcare workforce until we were really deep into those first 3 or 4 variants, the COVID index variant, and then some of the successive mutations. When we were still seeing people very acute, we were still seeing that caregiver burden being very high. We were still seeing a lot of people burning out, especially nurses and nurse practitioners, the entire healthcare workforce. What was happening is that I was practicing in this nationwide telepsychiatry network that was scaling across the country. I think we were in 42 states at that point. What was happening was the people who were presenting for intakes as patients in that role were healthcare providers. They were physicians and nurse practitioners and physician associates and RNs. And I was just shocked at the number of my fellow coworkers who were finally admitting that they were burning out, that they were developing caregiver role strain, that they were really in the midst of compassion fatigue. And so learning to relate and suddenly thinking, oh my God, one day I woke up and I thought, I'm that person. I think we all got a little jaded and we all sort of pushed as far as we possibly could. And some people had different breaking points, but we all got there eventually. And I think it points to the danger of just keeping that momentum going and just assuming that you're always going to do what you do. And to some of us, that's comfortable, right? There's comfort in routine. There's comfort in making sure you meet those goals you set for yourself or your employer sets for yourself every day. But I don't think we gave ourselves a lot of grace. It was hard for us to look in the mirror and say, you know what, this is taking its toll. Look at these bags under my eyes. Look at the stress in my face. Look at the cortisol hump that's developing between my shoulder blades because of all the stress and stress hormones that are coursing through my body. I think we're also really bad at saying no. It's the dirtiest word to us in our industry to say, no, I'm not going to take additional overtime. No, I'm not going to pick up another shift. No, I'm not going to do that because it's actually injurious to my self-concept and to my health. Learning to say no was really hard. So there's danger in doing that because I think what we saw was either this overstimulation pathway that then ended in a crash and burn with a depression that was really recalcitrant and really hard to treat, or it ended up becoming a true trauma manifestation. And in the PTSD model, we were actually seeing things like flashbacks, abreaction. We were looking at nightmares, all of that stuff that went along with more of those acts of God and nature. And we were actually seeing PTSD developing in our fellow healthcare workers and folks who were on the front lines, especially. And as you know, that's no walk in the park to treat either, not for the patient and not for us as providers. So the danger is that acute stress, that environment we're placing ourselves in willingly, altruistically every single day. Remember, it becomes part of nurture. This is how we're nurturing and how we're setting up our environment. And at some point, that translates to biological changes. The brain will stop doing business as usual and it will struggle. And that's an epigenetic function. So we're inducing those changes by willingly immersing ourselves in that environment. And that can become a biological problem, a healthcare problem. And then it's harder to treat.
Thank you so much for emphasizing on that one. And also, the danger in ignoring high functioning exhaustion. And what I often see in healthcare workers and nurse practitioners is that it erodes their executive functioning slowly but steadily, right? Clinicians will also be charting, diagnosing, and showing up for shifts, but their empathy, reserves, and decision making sharpness are slowly shrinking. So the silent grief increases the risk for medical errors, relationship strain, and eventual collapse into major depression or severe burnout.
Yeah, we saw a lot of that, unfortunately. I'm sure you did too.
Yes. Especially during the height of the pandemic, where a lot of nurses and also nurse practitioners got overwhelmed.
Yeah. Yeah.
Thank you. Now, when do you think medication can support someone experiencing chronic overstimulation, anhedonia, or depression or burnout? And what does thoughtful, ethical prescribing look like in these cases?
I think it's always interesting to know when we've crossed that threshold. And I guess for me it's sort of one and the same. We can use an acuity model to really think about when we've got impaired function, we can make a diagnosis. And
Mhm.
then the question becomes, and for me the final common pathway is always just knowing what you're doing. I think psych nursing has always been sort of written off as sort of something that is intangible. It's I don't know how your colleagues treated you, but when I first declared that I was going to become a psych RN, even before I became a psych advanced practice provider, it was sort of, well, look at him, just sort of deciding he's going to phone it in. You surrender your scrubs and your stethoscope, and you're going to go just do med passes in a psych facility and just pass pills. It's that sort of turning on your profession or because you can't hack it. I think it's really the opposite. I mean, I think for us, there is both an art and a science to this. And I think the art piece has to take over to say all roads lead to Rome. So to really understand what you're doing, I think the work that a psych nurse does is some of the most elegant and artful because we have to understand that we are actually working with genetics. I've been talking a lot about epigenetics. No matter how you do it, with someone who's got a diagnosed biological mental health condition, those neural networks are not communicating effectively. And that's usually because we've seen some suppression. We've got a switch, an epigenetic switch at the beginning of a gene that's turned off. That's caused atrophy in that network enough to where those neurotransmitters either aren't persisting in the synapses long enough, or they're being taken up too quickly, or we've got an enzyme, or there's something wrong with just the proximity of these cellular neighborhoods that are usually really close, as neighbors. If you and I are two nerve cells in the serotonin network, we're usually so close together, just a micron apart, it's really easy for us to communicate. Epigenetically, overstimulation, chronic stress, all of these things we've been talking about today, if that causes that epigenetic suppression in the growth genes in particular, we shrink back just far enough that it's really difficult for us to talk. And we're trying to reassure and cheer each other up, and we're not getting it done. How will you go about fixing that as a psych prescriber or a psych clinician or a therapist of some kind? As I said, talk therapy, brief interventions, good quality enriched conversations can start to attack that problem by reversing some of that epigenetic suppression, but so can medication. The mechanism is slightly different. But in thinking about someone who is really debilitated by these symptoms, in the short term, that monoamine theory that we all learned in school is coming up on 60 years old, and it's wrong. So we've always just thought, well, what we're going to do is start a medicine, and we're going to try to hold whatever neurotransmitter is supposed to be working in this synapse out in the synapse longer. The question has always been, because we know this, within 5 half-lives of that medication, within 5 doses, the therapeutic level of that medicine up amongst these cells is optimum. Why is the problem still taking 4 to 6 weeks to get any better if we do see a response? It's because that's not the primary mechanism of a medication. Yeah, acutely, we're causing this little talker in our little relationship. He's talking louder, he's talking longer. He actually has to get tired. He has to get hoarse, and eventually he has to send a postcard over here. He has to write a little note that says, dude, this isn't working. We have got to grow back together. That postcard, if you want to think about it that way, induced by medication, is actually the reversal of that epigenetic suppression. We start to then see these cells migrate back together. We get a wave of brain-derived neurotrophic factor. We start to see cells regrow. That takes about 4 to 6 weeks to happen when we do it in the lab. So we're working genetically, whether you're writing prescriptions or doing therapy or both. You're actually going to try and, as quickly as possible, reverse that epigenetic change and regrow some tissue. So we're all geneticists in this work. You just probably didn't realize it. So however you prescribe or however you provide that intervention, it's got to be personalized for the problem, but you're really doing the same thing. You're just using multiple modalities or multiple strategies to get that work done.
Thank you for sharing that, Dr. Josh Hamilton, and particularly the epigenetics part is really interesting, which a lot of new grads could definitely dive into and definitely ruling out the relationship between genetics and mental health is there's a strong correlation. And one thing that we are learning right now, you really need to do a thorough history and know where the patient is coming from. It's very personalized. And also with my practice right now, I kind of like avoid polypharmacy and basically very deliberate and simple in terms of also incorporating the 5 M's of mental health. I think I've been posting this in my social media about meditation, meaningful engagement, mastery, movement, and medication adherence, which I think is very effective in lowering down also their pharmacological interventions with a lot of patients. And this allows them to recalibrate the brain, not just simply medicating them, and also imposing like medication at all times.
I think you can add to that
Yeah.
if you wanted to. Precision medicine is sort of a buzzword right now.
Mhm.
But you could look at, and again, what does the patient want? What makes the most sense to that person? What do they think is going to work best? So, some people are very averse to taking medicine, and some people that's the primary intervention they want from us. So listen, and then realize that your arsenal of choices, if you are going to prescribe medication, think a little bit more about objective tools that you may be able to employ. One of the things that I've stood on my soapbox about for years has been using pharmacogenomics a little more effectively. There are some well-studied recommendations. The CPIC, PharmGKB, even the FDA has opinions, and there have been genes that have been studied kinetically and dynamically to help you make a better medication choice earlier in therapy to help you avoid polypharmacy and multiple failed drug trials. So
Mhm.
use those tools, learn about them. That should be part of what we're teaching students. That should be part of our educative vernacular, especially those of us who teach. We should be surfacing that as a tool. And I think the other part is what you mentioned. We could be very non-allopathic. We could think about non-Western interventions. I do frequent referrals to massage, acupuncture, acupressure. I happen to be a Korean hand therapist. There's real good science behind that. You can think about more somatic modalities, TMS, cranioelectric stimulation. Uh, if people want a more functional approach, then we're very interested in supplements and herbs with good evidence. We all need to be able to speak that full language and to cobble together a treatment plan that's palatable and that the patient has some choice and some input into. That I think is the most important thing.
Also, it's always personal and also individualized plan of care for our patients. So thank you for emphasizing that. And with your experience in regulatory science and nursing education, how can we better prepare mental health providers to address overstimulation, tech overload, and emotional fatigue?
I think for us as role models, one of the things that I would like to see us talking more about, for ourselves in particular, is that it is okay to set limits and for us to learn how to decide how many hours we want to work, how our time is best spent, and how we can preserve that essence of who we are, that caregiving mindset, that compassionate, empathetic sort of approach that we especially should be known for, to conserve that and not to be part of the problem. So I think as much as anybody, we all sort of have that slippery slope of overusing. If it's not social media, how many of us are stuck in our electronic medical records every single day, charting and looking at psychometry and overstimulated by all of these data that are flowing in? I recently completed a project with an industry partner on digital phenotyping in the mental health population. And they're actually tapping into our wearables, our Apple devices, our Fitbits, looking at the movement metrics on our phones, Apple Health, to sort of understand how those data can characterize decompensation in a mental health illness or improved coping. Just to say, this is a person who's leaving the house and running errands, and we can know that. This is a person who's getting their steps in. And when they don't, for us to have a flow of meaningful data to actually keep tabs on a patient outside of a visit, it's fascinating. But think about that constant barrage of data input in our lives, in our professional lives, in our clinical lives. Setting limits and making meaningful use of data, stepping back from the tech, reducing our own screen time. And
Mhm.
then in terms of emotional fatigue, I think that's part of it. I was really burned out coming out of the pandemic, and I wasn't feeling like I was good for anybody. I certainly didn't feel fulfilled at the end of a clinical day. I can only assume that many of my patients had a sense that my heart was not in the work for a period of time. It's hard to admit that. But knowing that and self-assessing and realizing it's okay to step back, curtail, maybe change your vantage point. I was fortunate in that I could move a little farther away from that point of contact where I felt like I was less effective, but I was doing a lot with industry. I was consulting on new products, new services, getting up at the podium and sharing what I knew, being really honest about what my limits were. But as a nurse, I think it's one of the best things. We started that way, just to say if you're not driving well in this fast lane anymore, turn that right-hand blinker on and move over to the right of the road. Don't stop, but think about how you're spending your time. Make sure if you're going to do it, make sure the juice is worth the squeeze. And for many of us, that means you got to hold a mirror up and figure out where your time is best spent and be a good role model that way.
Wow, that's simply amazing how you emphasize on role modeling. I think that's what we are good at, and also mentorship. And I think we have to do that for the next generation of prescribers, and also not just teaching them about depression or anxiety, but also assessment of overstimulation load. Because teaching our patients about digital fatigue, boundary erosion, and neurobiological overdrive. And that means integrating those modules in the current programs and continuing education is really good, which you're good at. And you've been doing a lot of interesting topics in the podiums as I followed you in your social media.
Yeah.
And with such a dynamic portfolio, Dr. Josh Hamilton, clinical, educational, regulatory, consultative, how did you personally avoid burnout or decision fatigue?
I kind of touched on it before. I kind of see our lives as nurses, especially those of us who are trying to do multiple things, have multiple interests, and I think we all do. It's you can sort of think of your portfolio of activity as I think about dials. You've got this dashboard and you've got all these different things you can do. And I think at any given time, it's a recipe. Think about your dials as piloting an atomic submarine. In order to get it where you need to go at the correct depth with the best efficiency, use the least fuel, make sure the mission is accomplished, you've got to get the right balance of steam pressure. You got to make sure the propeller is going at just the right speed. You've got to make sure you're heading in direction are correct. When something's not going well and you're navigating poorly, I think that's the thing. When I lie down at night, I like to sort of reassess sort of what I accomplished in a day, in a week, in a month, in a quarter. And if I feel like I'm on track, that's great. I sleep better. But if not, I think just being aware of that, meditating on where you are at any given time for a moment. Are there skills that you need to add that could give you different options? Are there micro credentials or different, if you get a telepsychiatry certificate, you get certified as a certified telemental health provider. You could add telehealth, move out of the clinic a little bit, adjust that dial a little bit. I think finding that right balance to say, maybe I'll need a little more of this and a little less of that, really adjusting that recipe to make sure that you're heading where you want to go. For me, that's been the model I use in my head. That's the image I conjure when I'm trying to figure out the right balance for me. And I'll admit I change it frequently. I like to take on project work. I'll take on a consulting job that lasts a few weeks or a few months. I network along the way. I meet fascinating people. I get involved in podcasting and I author manuscripts or I do some presentations where I get to partner with someone I've never presented with before. That I find fills my cup. It teaches me new things rather than just reading a journal article or passively listening to something. I'm involved, but I'm learning. And that allows me to really readdress my clinical practice, usually with a different vantage point or with a new skill set or a different viewpoint that allows me to bring another layer. And it allows me not to feel fatigued or burnt out in my work. So I've been doing that now for nearly 3 decades. So something's going well. Adjust your dials.
Yes, I can feel your drive and fuel to share your information too, which I think you're very generous at sharing your learned knowledge and experience. And with all of your experience, we were kind of like learning and assimilating it, and we wanted to emulate you in the long run. So thank you so much for emphasizing how you do your time management, and how also you prioritize, and how you love to work with other people which you haven't worked with. I think that's very important to nurture other or next generation prescribers too. And what's one thing you wish more people knew about taking care of their mental health in this hyper-connected world, Dr. Josh?
I wish more people knew that it was okay to be human. It's okay to extend yourself the same grace that you would expect from someone else or that you would give to someone else. It's that self-compassion piece. The other thing that I think is important is to realize that in this hyper-connected world, what you're seeing out there, that reality that you're using as a metric, as that yardstick to decide whether your life is good or bad or better or worse than someone else's, it is such an artificial representation of what's really going on out there. I mean, compare what you do when you're death scrolling with your insomnia on Facebook or Instagram, watching all of these happy people out there taking their vacations and having gourmet meals and talking about their loved ones and their children and their marriages. What we still see are going to be polar views of the world. We're going to see very black and white representations of situations that are either artificially happified, that's my word, trademark, or are doomsday and horrible. So there's this very polar echo chamber effect in what we experience, especially digitally. We could talk about the news media, we could talk about television, anything being piped into our lives digitally, I believe, has a very polar slant, one way or another. So depending upon what you're looking for or what you're experiencing, it's either that echo chamber that reinforces what you already believe or so repugnantly challenges what you believe is true, it's going to create that sense of overstimulation and cognitive dissonance for you. So I think just knowing that, admitting that, and realizing that that stimulus is probably not healthy on either side of that. The pendulum has swung too far either way. So realizing that, recognizing that, and stepping away from that when it's necessary. I think giving yourself permission and grace to do that. I have made a concerted effort to connect in real life to people in my world, reconnect with people with whom I maybe have fallen away from, just to say that's what that's about. That's what's out there. The world is still very gray. There's still a lot of good and bad in everyone in various proportions. Just to say that go out there, immerse yourself, get to know those people that you maybe have a lapse in a relationship or a conversation to reinforce that it's okay, that there are gray areas, that there's good and bad in everyone and everything, including ourselves, and that it's okay to talk about it. It's okay to be honest and to connect with each other. So to your point, mentoring and peer support networks and all of that self-care stuff that we teach our patients about, I wish we did that more for ourselves as well. And then just being aware of the fact that what gets piped in our reality, our environment, the things that have that risk of causing some neurobiological stuff that we don't necessarily want, is pretty artificial and often very polar. So I wish more people knew that and operationalized it enough to say those real human relationships with known quantities, people I trust and care about, should take precedence over this hyper-connected digital world that we've constructed over the last 20 years.
Thank you so much. And I also impose, just to piggyback or add on, I also impose a micro offline zones throughout my day as a prescriber and also as an educator, wherein I put my phone in another room and I let my brain recalibrate. And I also teach this to a lot of my patients. And I always emphasize that our brain is not a machine to be optimized, but it is an ecosystem wherein it needs to be nurtured. So slowing down isn't laziness, it's a neurobiologic maintenance. And in a world where we what's always asking for more, the most radical thing that we can do for our mental health is to create a space for less. And that's basically what I've noticed with my practice too. So thank you, Dr. Josh Hamilton, for emphasizing all of those tips and tricks that you've been teaching us on how to survive this hyper digital world. And what is your call to action for all the new grad that are transitioning to their practice and anybody that is very interested to know about your epigenetics?
I think it's that we don't just say it, we mean it. We are lifelong learners. And I think we all just rolled our eyes, right? But I think there are ways to do that. So the call to action is never stop learning, but make that experiential. So I think to the extent you can subscribe to your favorite journals and your favorite listservs and do all of that CE that comes out once a year that we have to do, and that's very rote. I think one of the best things that we can all do is continue to network and make sure that we assimilate and learn at least 1 or 2 new skills every month or two. And that should be relational. Learn from a trusted colleague. Get out there and try new things. Move outside of that lane of what you're trying to perfect in school, to become better about transitioning patients to a long-acting antipsychotic, or learning more about the glutamatergic theories of treatment-resistant depression. But then to think about, that's the lane we trained in. But one of the things I needed to do was let go of that Western view and actually go spend some time with folks who are practicing more holistically and experiencing that. My call to action is go do something that you're a little uncomfortable with. Try something dangerous every single day if you can, just to see what you can learn from it. And there may be a lesson that makes you a better provider or a more compassionate human. So my call to action is never stop learning, but learn interactively and relationally, and don't do it online if you can help it.
Yes, we have in-person conferences that we can join into, and I think your network is your network, as they said. So that's basically true, that you are inspiring us on how to do best each day. And as a provider, we're learning each day and also applying evidence-based practice with our patients to fill in those gaps between what we're seeing to improve our mental health care outcomes. So Dr. Josh Hamilton, if anybody would like to connect with you, where can they follow you? And do you have any special projects or anything that you would like to do in the next succeeding years?
I've got a website, so if anyone wants to continue these conversations or connect with me, I always welcome Zoom coffees. I take many of them a week. Anyone who'd like to chat about anything, I'll open that invitation. My website is www.askjoshhamilton.com. You can reach out to me that way. You can learn about what I'm working on at that website. There's some interesting things that I'm working on, some projects that are as yet still a little bit confidential, but a lot of interesting things coming on with new disease state education, some really interesting stuff coming out in the PTSD space that I'm doing some consulting work on. And then, of course, learning a lot more about treatment-resistant symptoms and syndromes and recalcitrant sorts of situations. So we've got some exciting things on the horizon that should be rolling out later this year, probably in Q4. So I've been involved in some great dialogues, some great conversations, and I'm excited for some of this stuff to become more prominent and maybe a little more public in terms of our awareness and our ability to try some new things. So always consulting and always learning myself.
Wow, that's what I love about you, is that you're evolving and transforming as you go along. And over the years that I've been following you, I'm just amazed by what you do, speaking to different people. And I think mentorship, what I see from you is that you're nurturing also the young and helping us out to grow and think outside the box. And that's one thing that I learned from you today. So thank you so much, Dr. Josh Hamilton. So once again, for all the followers that are out here and podcast listeners, please follow his LinkedIn. He's also there. He's amazing. And he can answer some questions for you. And please don't forget to like, subscribe, and follow him too. We support each other, and he is one of the best psych NP that will be a great resource for all of you guys, especially for those who are transitioning to their own practice. Thank you so much, Dr. Josh Hamilton, for your generous time. Once again, congratulations on all your endeavors, and I'm just excited by all your projects, and I know you'll do amazing, great job at it. So thank you so much for allowing us to share this space with you and this platform, and I could not thank you enough on this time that you gave us today. So thank you.
Thank you again for the invite, and congratulations to you.
Thanks for listening to Mindful Moments with Pedro Morante. Be sure to follow the podcast so you'll never miss an episode. If you find value in our time together, leave a quick review. It helps more people discover the space we're creating. For updates and more reflections, follow us on social media. Until next time, take care.